Hello everyone. I am Dr. Venkatesh Babu. I am surgical oncologist at Fortis Hospital, Bannerghatta and Cunningham Road. And with me, Dr. Sarat Chandra Pingali sir is there. He is a senior surgical oncologist at Fortis Hospital, Bengaluru. So, as you all know, biopsy plays an important role in diagnosis of the cancer. So, today we will try to understand few things about the biopsy. So, sir, how do you usually diagnose a cancer?
All of us know cancer is a disease of the cells, especially a disease related to the abnormal multiplication of the cells. So cancer being a disease of the cells, it is also always diagnosed under the microscope only. So this is what we call biopsy or cytology.
So what are the types of biopsy, or what are the means by which you get tissue for biopsy?
The simplest way to get the tissue for analysis is by doing a fine needle aspiration cytology, wherein a thin needle is passed into the tumor and the cells from the tumor are pulled out. We call it fine needle aspiration cytology, and the cells are spread on the slide and then stained, and then the pathologist interprets whether it's a malignant tumor or a benign tumor. This we call fine needle aspiration cytology or FNAC. Even better way to diagnose cancer is by doing a biopsy. The commonest way we do biopsy in our clinical practice is by doing a true cut biopsy, which is also called core needle biopsy, where a little bit of wider needle than what we use in an FNAC is fired into the tumor, and then we obtain the tissue. We process the tissue obtained, and then we make a slide out of it. We apply the stains, and then the pathologist gives the opinion whether it's a cancerous tumor or a non-cancerous tumor.
Okay, sir. Sir, what are the advantages of true cut biopsy over fine needle aspiration cytology, and what do you mean by excision biopsy?
So the first question, true cut biopsy versus FNAC. So true cut biopsy is always better than FNAC because we get a bigger chunk of the tumor tissue for analysis in true cut biopsy. FNAC just pulls out blood stain smear like thing, and then we just look at the individual cells actually. So true cut biopsy is definitely better because you get bigger chunk.
Yes, sir.
So
we get to know about the tissue architecture.
Yes, we can diagnose cancer with more certainty and more surety with a biopsy than with an FNAC.
Okay, sir.
So the second question which you have asked, is there any role of removing the tumor directly without doing a biopsy, initial biopsy? It is always good practice to do an initial true cut biopsy before removing the tumor, because it's always better to have and good to have a diagnosis before we perform a surgical procedure. But sometimes if repeated true cut biopsies don't yield adequate material, or due to any other technical or logistic reasons we are not able to do an adequate true cut biopsy in any given case, then sometimes we do consider the case for a removal of the tumor directly without doing a true cut biopsy.
Okay, sir. Sir, are there any instances where you avoid doing biopsy before a definitive procedure?
Most of the times we do biopsy before planning surgical tumor removal. But yes, in clinical practice, as per the guidelines, we don't do biopsies for some of the tumors before going for surgery. For example, somebody comes with isolated mass in the kidney, a kidney tumor, and when you do a CT scan, it looks like a malignancy. For tumors limited to the kidney which look malignant on the CT scan, we are not supposed to put a needle into it and do a biopsy. In such cases, we consider direct surgery. This is one instance. There are other instances also, like for example, somebody comes with a tumor in a very inaccessible area, and the scan findings are very much consistent with a cancerous tumor, like for example, retinoblastoma of the retina, or some tumor, optic glioma behind the eyeball, which are not very accessible sites for biopsy. Similarly, for certain tumors situated very deep in the brain or in the brain stem, where biopsy is not easy, so certain situations tumors are diagnosed based on scan alone. But these are like rare exceptions. Most of the times we do biopsy before proceeding with the surgical removal of the tumor.
Sir, we have heard a lot of rumors about biopsy, that doing a biopsy will increase the spread of cancer, will make it grow very fast, will make it spread very fast. What are your views about it?
So most of the times biopsy does not result in spread of the cancer, but medically, because you have asked a specific question, we have to clarify that when we will not do biopsies for some tumor that is found. Suppose somebody comes with an ovarian cyst, a complex ovarian cyst, ovarian mass, and this is the only site of disease, then we are not supposed to do biopsy, because sometimes there could be spillage, but these are like exceptions. Most of the time, biopsy doesn't per se result in cancer spread. Ovarian tumors is one exception. The other thing is isolated ovarian tumor, meaning there is no disease outside the ovary. It is entirely limited to the ovary. Then we don't do biopsy. We straight away go and remove the ovary itself. Similarly, for an isolated kidney mass, we don't do biopsy due to certain reasons. So these are the two situations where we generally don't do biopsy: kidney tumors and ovarian tumors, limited to the organ of origin.
Okay, sir. Sir, we encounter certain situations in our clinical practice, like most of the people undergo biopsy somewhere else and they come to us. What are your suggestions when patients from who have visited a general physician?
Yeah, this is important. From patient point of view, suppose we are staying in Bangalore right now, so somebody from West Bengal comes with a biopsy report of cancer. Definitely not specifically West Bengal, from any far off place, if patient is coming to a bigger city for cancer treatment or any such thing, it is advisable that they collect the blocks and slides if possible, because as I told you, the biopsy process would have been done in the lab in a local area, and they would have reported it as cancer, and they come to the doctor in the city with a report of cancer. So sometimes as clinicians we would like to doubly confirm that it is really cancer and not something else, in which case we have two options. When the patient comes to us at Bangalore from a far off place, we either do a repeat biopsy for the patient, or we would like to take a second look at the blocks and slides that they bring from the place where they have undergone the biopsy. Okay. So it is generally a good practice for patients coming from far off places to come to the consultant with the blocks and slides. They have to specifically ask for that in the lab which has issued the biopsy report. So that would avoid a second biopsy procedure when they come to us for consultation.
Okay, sir. Sir, are there any additional steps or tests you do on the biopsy specimen, or is it just a histopathology?
Most of the times it is, so the technical, the patient calls it biopsy report, but technical name given for that is histopathology. Histopathology is different from cytology. Cytology means pathology doctor looks at the cells and gives the report. Histopathology means he looks at the tissue itself as a whole. That's the biopsy. The technical name for biopsy report is histopathology.
Yes, sir.
So
are there any additional steps?
Yes, most of the times it is only histopathology which is sufficient for us to arrive at a diagnosis. Okay. But certain times we would like to do further molecular typing. Suppose histopathology is suggestive of a lymphoma, which is one of the cancers. So we would also like to know which subtype of lymphoma it is after we feel it is a lymphoma. For that they will be adding particular molecular reagents, additional chemical reagents. We call it immunohistochemistry or IHC. So this is a very important part of the diagnostic workup in certain of the cases. But most of the times we can arrive at a diagnosis without doing IHC.
So this is about the basics of biopsy, and biopsy plays an important role in diagnosis of cancers, and it is the confirmatory test for diagnosis of the malignancies. And most of the times it will be biopsy will be able to give us results whether it is a malignant tumor or a benign tumor. Sometimes we might have to do additional tests like IHC to know the subtype of the cancer. Thank you.
So hope this information is